there's a lot, it goes fast. That is what you should study for the quiz that will be the beginning of next class, um, which is a quiz that is typically in multiple formats. Typically, it's like a matching, uh, short answer, and multiple choice. It's kind of a grouping of stuff. Yes, it definitely helps to go back and listen. Okay, so infections. A microbe is described in certain ways in order to help classify it. And the usual definitions that go with that are pathogen, which means the type of infectious agent. You could say microbe because it doesn't necessarily have to be a bacteria, it could be all kinds of things. Sure. Portal of entry is how the pathogen or microbe gets into the body in order to begin to divide inside the body and start an infection. So, depending on which type of infection you're talking about, depends, there could be a different portal of entry. Pathogenicity is characteristics of the pathogen or microbe that make it easy for it to cause an infection, the different things that it does to try to evade our body or to try to stay around. And virulence is the strength. So that really is how much exposure do you need in order to actually have symptoms from the pathogen. Sometimes it takes very minimal exposure to get an infection, and sometimes it would take a prolonged exposure to get an infection. Typically, when people are talking about infections, they can sometimes, especially if they work in epidemiology, will sometimes refer to this epidemiologic triad, which is looking at the pathogen's factors, host factors, and factors of the environment that sort of come together and potentially increase the likelihood of an infection, especially increase the likelihood of an infection that will um, hurt many people. So the agent factors were things that we were just talking about: what kind of pathogen it is, what are its characteristics, how does it get in, how strong is it, how virulent it is. Host factors are things about the person's makeup that might make it easier or harder for them to get an infection. So maybe they are immunocompromised because they're on chemotherapy. Maybe they work at a job where their exposure to different infections is higher. Maybe whatever they're doing in terms, if they're, um, whatever their nutritional status is, things like that, that contribute to the host's health. And different environments make it easier for a person to get an infection or for the infection to pass, especially um, if there's close contacts between people because of crowding and housing, or if there's contamination that multiple people have been exposed to. So, types of infections are classified by their structure under the microscope and how complex they are. Viruses are the least complex. They are just a piece of DNA that is wrapped in a capsule that relies completely on the body. Viruses are considered intracellular parasites, meaning they have to go inside our bodies in order to divide and um, to, to work to cause an infection. Bacteria are cells, they're just a little bit simpler than our own cells. So they do release what are called exotoxins, or they do actually take things from our cells that they need for growing, and they do cause like collateral injury, but they can live outside of our cells. Funguses are a little more complex, and then parasites are actually types of bugs. So it's important to know what type of infection you're dealing with, because that certainly changes the type of medications that you could use. Bacteria are the types of infections that we frequently confront, and they are the group of infections that have the most possible treatments because we have lots and lots of antibiotics that we can use. So if we want to be sure we're picking the right antibiotic for the patient, we have to be sure we classify the antibiotic correctly. So this is done by getting a culture. If you see this on an exam, it's always best to get the culture first before initiation of drug treatment, because you're more likely to get a better culture, one that gives you a greater sampling of the bacteria, if that culture is done before the patient is exposed to any of the medication. Certainly, if there's some weird delay, you wouldn't wait forever. But on an exam, this is what you're going to see. What should I do first? If the question is give the medication versus get a culture, the culture is always first. Sometimes the culture is ordered after antibiotic therapy has already started, and certainly that's not the fault of the nurse. But if you had the choice, you should get the culture first. The first thing that's done with that information is called a gram stain. The gram stain is looking at how the cell wall looks, the quality of the cell wall, by how it takes up a violet stain. So the culture Q-tip is rubbed on a slide and this violet staining is applied, and then you look under the microscope. A gram-positive bacteria has a less thick or simpler cell wall, and so it takes the color up easier. And that's gram-positive. And gram-positives in general are easier to treat and less likely to make the patient very, very ill, although of course that's not true all the time. Gram-negative bacteria has a thicker cell wall, and so it does not take up as much of the color. And this thick cell wall makes it sometimes harder to target, and that cell wall contains toxins which sometimes make the person sicker even when they start the antibiotic treatment. So gram-negative bacteria, generally the patient will be sicker. Of course, that's not always true. The next thing that we're looking at is the shape of the bacteria. The most common shapes are here, the circular or rod-shaped bacteria. Circular shape is called cocci. The rod shape is bacilli. The way they're shaped can help classify the the particular bacteria. The next thing that will be checked is how the bacteria utilizes oxygen. So we are aerobic creatures. We rely on oxygen for metabolism. If we run on an oxygen deficit, that can't last forever. Eventually, we will start to build up lactic acid, and our energy output in terms of ATP will be greatly decreased. So a lot of bacteria are that way too. They require oxygen in order to maintain their energy and keep dividing. There are some bacteria that are anaerobic, which means they do not require oxygen in order to feed their metabolism, to increase energy production and to live. So obviously that's a little more dangerous because they don't actually require us to be alive necessarily to grow. So you kind of use that information, the gram stain, the shape, the way that the way it metabolizes, and that helps the pathologist or the person looking at those slides classify what type of bacteria it is. And then the next question is, how will we decide which antibiotic is the best to use? Because there is an issue with antibiotic resistance. And the reason that is really our own problems. We caused this resistance issue ourselves. The two greatest risks, or the two greatest things that people do that can increase the risk of resistance to antibiotics, is taking antibiotics when they don't have a bacterial infection and not completing the course of antibiotics. And the reason that is because our own body is full of bacteria, good bacteria that we have a nice relationship with, that help maintain our homeostasis. But when we expose even our good bacteria to antibiotics, we can teach those antibiotics how to resist. We can teach that bacteria how to resist those antibiotics. Bacteria, even the good bacteria, is mutating constantly. And so um, bacteria that survives antibiotics because of mutations will then share that information with their neighbors. So if I had a virus but took an antibiotic and some of my own flora mutated to be resistant and shared that information with the rest of my bacterial flora, then if I become infected, my good bacteria can share that information with the bacteria that I'm infected by. So that's how that occurs. Um, so I usually, if we're all sitting with me in person, I would have you raise your right hand and solemnly swear that you will never force your primary provider to prescribe you a Z-Pak when you have a viral infection, which is usually the reason why people get sick if you're a healthy adult. Um, so we have to protect antibiotics as much as we can. This is how sensitivities and resistance are tested in the lab. So this um, plate is coated with bacteria, and the little white circles, like these white circles, are types of antibiotics that are placed on top of the plate with bacteria. Then we watch and see if, spreading off that plate of antibiotics, we see destruction of bacteria, then we know that that antibiotic would be effective against that bacteria. So you can see some of these look like they would be better than others. Like this one is killing bacteria around it, but certainly not as well as the one next to it. And this one is really, there's a tiny bit, but really not well at all. And this one looks like the bacteria is resistant. So that's how they figure out if this medication will be helpful in terms of treating the bacteria. Sometimes, obviously, this information takes a while. You'll know the name of the bacteria before you'll know the cultured sensitivity information, or the sensitivities can sometimes take up to 48 hours. So sometimes patients start a medication and then it has to be changed once this information is received. We always have to talk, at this point I like to mention that there are a large number of infections that are actually caused by hospital care. The largest grouping of hospital acquired infections are urinary tract infections. And this is often nursing implications. So how can we protect against urinary tract infections? Because those types of infections cost the patient in terms of illness and length of stay, as well as the hospital, because that's not reimbursed. If the patient is on Medicare and they develop a UTI related to care, then every bit of care that's done in the hospital is paid for by the hospital, not their insurance. So of course that's why hospitals care about that quite a bit. I see some typing on the side. Using sterile technique, correct. Which means all the pieces of the kit should be used. Last semester, before the pandemic, I was teaching a lab class, and I don't know if this was true for everybody, but lots of people were told to just like toss the fenestrated drape, the one that's shaped like a diamond. I mean, there's actually a purpose to that. It's helping keep the area around the urethra as sterile as possible. That's not something to get rid of. Clean it regularly, so we have to do proper pericare and keeping that area clean, away from bowel contamination. Anyone else have anything? Those are very good. so far. One of the other big things is to be sure that the folate is only stays in as long as it's needed. Right. So we have to be careful. Every time you insert the folate, you have increased the risk of infection. So you can't, there are usually policy and procedures related to having a catheter. You can't have a catheter just because of incontinence, um, because the longer a catheter is in, there's an increased risk of infection. So I work in surgery, so we're always thinking about how many days the catheter is in, if it is in, and trying to get it out as soon as possible. Um, so then the next couple of slides are going to talk about antibiotics in general. So antibiotics have both broad and narrow spectrum types. Broad spectrum antibiotics means it can target multiple types of bacteria, that it would work against multiple types of bacteria. Narrow spectrum antibiotics only are able to target specific types of bacteria and aren't used as often for that reason. Antibiotics have several different mechanisms of action. So when we were making those study sheets or like practice med cards, we were talking about the therapeutic class would be ridding of infection, getting rid of bacteria. The pharmacologic class would be things like this. What is the exact mechanism of action to get rid of the bacteria? And it could be that we disrupt cell wall synthesis, meaning usually that the cell wall is cut, killing the bacteria, or we could change the way the cell works by inhibiting production of protein and by doing things that make it harder to create DNA to replicate. So these targets will make the antibiotic either bactericidal or bacteriostatic. Bactericidal antibiotics are antibiotics that directly kill the bacteria. Bacteriostatic are antibiotics that prevent the bacteria from dividing, and so eventually they will die out because they aren't able to replicate. So when we organize the antibiotics, the overall therapeutic class is ridding the body of bacteria. Pharmacologic class will be these 4 different targets, either cell wall synthesis disruption, RNA DNA synthesis disruption, protein synthesis disruption, inhibiting folic acid synthesis, which is important for DNA synthesis. And then within these different pharmacologic classes, there will be families of antibiotics that fit in there, and then prototype drugs that we need to be able to recognize for our exam and the ATI exam. So I will continue to emphasize how to organize the medications as we go through. All antibiotics have these directions in common. All antibiotics, it's usually best to take on an empty stomach because they will be absorbed better. However, all antibiotics have a common side effect profile in that they can make people have GI upset. They can make people feel nauseated or hurt their stomach. So if the choice is between not taking the antibiotic or taking it with food, then it's always best to take it with food. So if the patient cannot tolerate it, taking it on an empty stomach, it is okay to take with food, although it's not preferred. The person should increase their fluid intake beyond what they usually take in, into the 2 to 3 liter range, to help prevent dehydration, just because infections increase fluid loss. You should not drink alcohol. There are certain medications that produce a reaction when mixed with alcohol that will make the patient sicker. However, all people with infections who are taking antibiotics should not drink alcohol because alcohol is dehydrating. So that's always the rule. But there will be some medications where that's even more important than usual. A person should always take the entire prescription as prescribed, even if they feel better. The last two are reasons why we might suspect that the antibiotic wasn't the correct choice. Maybe the person is actually resistant to the antibiotic that was chosen. So if they have a fever that is longer or persists past 48 hours, then the question is whether or not that's the right antibiotic, so they should call. If any of you work in the hospital, you probably have described fevers as temperatures that are above 101.5. In the hospital, that's generally what people describe as fevers. In the outpatient setting, a temperature of 100 degrees or more is considered a fever that people would call about. It'll be obvious on an exam if the patient has a fever or not. You won't have to think about it, but I just want to let you know that. The other thing is if the patient has symptoms from the infection after they've completed the antibiotic, then it's possible that they need more or it wasn't completely the right one. So again, they should call. So if the patient is taking an antibiotic because they have a UTI, but they finish the medication and they still have frequency and pain with urination, then they need to call because maybe it didn't work. Doesn't sound like it, at least. So that's the directions for all antibiotics. Common effects of all antibiotics. All antibiotics have the potential to cause an allergy. Some are more known for it than others, but they still all have that possibility. Certainly there's a range of presentation for allergies. It could just be the itchy rash, the hives, all the way up to anaphylaxis. So your advice to that patient is always dependent on the symptoms they have. If the patient has that itchy rash, they might hold the medicine until you talk to the provider. Remember, you're never telling anyone to stop a medicine because that's an order, a medication order, and that's beyond your license. What you would say, so that's really important, you never say stop. You can't say that. You can say hold until you talk to somebody. That's the difference. So you could say, let me talk to the provider and see if they want to see you or what they think if you should change the antibiotic, versus patients having trouble breathing or they have swelling in their mouth, then they need to go to the hospital. All antibiotics have the potential to cause stomach upset, nausea, vomiting, and a possible change in bowel pattern. When we're talking about diarrhea, it's not watery diarrhea, it's soft and more frequent. Increase frequency. So it's not watery though. Watery makes us concerned about a superinfection, specifically C. diff. So superinfections are infections that occur because of the antibiotic itself. So they're like infections on top of the infection you were trying to treat. C. diff, or Clostridium difficile, is a bacteria that normally lives in your colon. Everyone has a small percentage of Clostridium difficile that's living in harmony with other types of bacteria in your bowel. When you take antibiotics, it's possible that you could kill some of the normal bacteria in your bowel, allowing this Clostridium difficile bacteria to overgrow. And it's this overgrowth that leads to very watery, malodorous diarrhea. Occasionally cramping, sometimes not a lot of pain, but the diarrhea is usually pretty watery and profound. It can be very dangerous, especially for people that are elderly. Sometimes people have C. diff infections where this C. diff actually releases a lot of air and toxins, and it can cause something called a megacolon, which could lead to death. So it's something to be cognizant of and very careful about for patients. If the patient calls and says they're concerned that they have C. diff, but they don't have watery stool, then they don't have C. diff. If you got a stool sample and it was soft but not watery, they won't even test it because it can't be. The other potential superinfection or infection caused by antibiotic therapy are certain types of fungal infections. So you have normal bacteria living in the mouth and the vaginal area that have nice harmony going on. If you take an antibiotic and get rid of some of the bacteria, you can allow fungus to overgrow. In the mouth, that's sometimes called thrush, and people commonly think of thrush as having that white coating on the tongue that you can't remove. But there could be other symptoms of oral thrush or oral fungal infection besides that the patient might complain about, including that food tastes weird or their tongue doesn't feel good, like it hurts. So that's also possible. If good bacteria in the vaginal area are depleted from antibiotic therapy and there's an increase in fungal growth in the vaginal area, then there'll be an increase in itching and discomfort and a particular type of discharge that's White described as cottage cheese. So knowing this and knowing that these infections are, annoying, uncomfortable, and in the case of C. diff, potentially increasing mortality on the patient, what are things that you could suggest doing to decrease the risk of those infections? Probiotics. So what type of probiotics, or how would you talk about them? Because there are different ways to give probiotics. So yogurt is definitely one. It has to be yogurt that has lactobacilli in it, um, and can help protect the body by, instilling that good bacteria to help keep the good harmonious relationship, not allow one to overgrow. It's not all dairy. It's really what is in the yogurt itself. Yogurt itself contains some of the lactobacilli um, probiotics. They're present. The milk itself doesn't do that. Any other way to get fermented things like kombucha? Yep. Or kefir that has probiotics in it. There are over-the-counter probiotics, but you have to be careful because that's a completely unregulated industry, so you never know what you're getting. Just allowing Scott an opportunity to finish his thought. Not necessarily. Alcohol and caffeine can change the metabolism of the medication potentially, or increase risks for certain antibiotics if they cause insomnia, or again the dehydration or the disulfiram reaction, which we'll talk about later. Um, the other thing that you can do is take over-the-counter probiotics, and anything you have to just be careful that the patient isn't picking the cheapest one, because there was a study done where different types of probiotics were tested to see what their actual content was, and some of them just contains like sawdust and actual like E. coli bacteria rather than the healthy lactobacilli, which is what you're looking for when you're trying to give probiotics.
I'm just.
So,
Oh,
go ahead.
oh, sorry. I was actually just genuinely curious because I am into that stuff. Does it matter for when you take the probiotic you said the different kinds matter. Does it matter if it's in a
Hmm.
pill or some probiotics, you see that are in a fridge? I always wonder, does it matter because it's supposed to be like a live bacteria? So does the pill, is that like super, taking it in the pill form, is that super effective?
It depends on the species of lactobacilli that are present. There's like subspecies of lactobacillus, and there's three main lactobacillus that are the best. And so the best over the counter probiotic is a pill called Florigen, but it's also the most expensive because it
Okay.
contains all three of the probiotics.
Okay.
Um,
I was just
there
genuinely
is
because I like that
sure,
stuff.
sure. There is some people that say like, well, I don't want to take a probiotic at the same time as I take my antibiotic, which I guess the worry is that like they'll counteract each other. Like the antibiotic will kill your probiotic. I don't know. Theoretically, that's possible. I don't know that anyone's ever done a study to show that that's the case. But
Okay.
in general, you could always separate it, and then you wouldn't have to worry about it.
Okay.
Um,
Thank you.
sure. So that all that information that we just talked about is what could potentially be on the quiz for next class. So now we're going to go to our lunch break, and when we return at 1 o'clock, we're going to start the long and painful antibiotic journey. So do not eat a lot because it's already not the most exciting material because I want everyone to stay awake. So I will see you at 1 o'clock.